Hey guys, I printed out the rhythm strip. I think it's Asystole. No, you fool. That's clearly PEA. You can tell by Are you telling me we forgot how to read rhythm strips? Oh no! Oh man, if only we remembered our cardiac arrest rhythms. Now this patient's going to pass away. Oh no. Hello everyone and welcome back to Amateur EMS. So today we're going to be diving into an essential topic for paramedics and ALS providers in general, cardiac arrest rhythms. We're going to be covering 4 critical rhythms, including VFib, pulseless V-tach, asystole, and PEA, or pulseless electrical activity. So let's go ahead and get started. So some things to note, cardiac arrest is one of the most life-threatening emergencies that we're going to face in the field. Recognizing the rhythm is critical because it determines the treatment pathway. Today we're going to focus on 4 key rhythms that we talked about earlier, and we need to note the EKG rules of interpretation. Now we've talked about this before, but what we want to pay attention to here is we want to look at the P waves. We want to make sure that they're upright. We want to look at the PR interval. Is it less than 0.2 seconds from the QRS complex? How many P waves are there? Are there more than one? Is the QRS complex less than 0.12 seconds? And do the P waves and the QRS complexes match up? Do the P waves match with the P waves, and do the QRS complexes match up with the QRS complexes? So a really big one here is going to be, are there any P waves? So how many P waves are there? So rule number 3. Another one is rule number 4, the QRS complex. Is it less than 0.12 seconds? You're going to see a lot of them aren't that way. Here's just a quick little table. If you guys are interested, you can see that for asystole, for looking at the P waves, there are no P waves. PR interval, there's none. The P waves, there's none. The QRS complex, there's none. The PQRS matching, there's none. And we can see here for the PEA, it may vary, it's rhythm dependent. For pulseless V-tach, there are no P waves or it's dissociated. There's no consistent PR interval. There's, again, no P waves, or if there are, they're buried beneath it. It's wide, it's greater than 0.12 seconds, and the PQRS matching is dissociated. For VFib, none of these match up at all. So for VFib, or ventricular fibrillation, what are we looking for? Well, it's a chaotic, disorganized electrical activity. There's no discernible P waves. The QRS complexes or T waves can either be coarse or fine fibrillation, and you're going to see fine fibrillation almost matches up with the systole. Coarse is easier to defibrillate than fine, it's just more simple to recognize. And why does it occur? It can occur for a couple different reasons, like an acute myocardial infarction or a heart attack, a severe electrolyte imbalance such as hyperkalemia, hypomagnesium, cardiac ischemia, or structural heart disease. So here's our first look at an image of VFib or ventricular fibrillation. And you can see here that it's more coarse, it's more obvious, right? So we can see these waves, it's kind of irregular. It's not so much V-tach, and you can see that they're just this waves, it's just nonsense. The QRS complex, it's not really sometimes going to be greater than 0.12 seconds, although these, some of them you can argue are, some of them aren't. We can't see a P wave anywhere here, so we can't figure out about a PR interval. Another one here is more of a fine VFib, and you can see it almost looks like a flat line, but you can see the little waves here. That's going to be another indication of ventricular fibrillation. So you can see we can't discern what a P wave is. They almost all look like P waves, but really these are the QRS complexes that are just fibrillating or they're firing off at rapid rates, and the patient isn't perfusing. This is one of our shockable rhythms. So the treatment for VFib is going to be CPR with a BVM. You want quality compressions first. You want to consider defibrillation, since this is a shockable rhythm. You can do epinephrine every 1 to 10,000 every 3 to 5 minutes, depending on your local protocols, but this is just basic ALS or ACLS guidelines. You can use antiarrhythmic drugs such as amiodarone or lidocaine. For Annabelle Fire Department, we would consider lidocaine. We're not going to go over a full code algorithm for any of these, but these are just baselines of what we can consider. Now, there's a whole lot of other medications we can consider as well. For pulseless V-tach, what are we looking for? Well, it's a wide QRS complex. It's greater than 0.12 seconds. The heart rate's usually going to be greater than 150 beats per minute. It's not going to have a discernible P wave. And we want to check for a pulse. That is huge. For all these rhythms, we want to check for a pulse. But for pulseless V-tach, it's very important because if they have a pulse and it's V-tach, we want to consider synchronized cardioversion. We don't want to consider defibrillating these patients. There's a huge difference. Why does it occur? It can occur due to hypoxia or ischemia, which just means lack of oxygen. It can be caused by cardiomyopathy, scar tissue from previous myocardial infarctions. It can be caused by drug toxicity or electrolyte disturbances such as hyperkalemia. So there's a couple routes, and there's a couple more we didn't mention. Here's an image of V-tach, and we're going to assume that this is without a pulse, although we always want to do a pulse check here. We can see we have these really wide QRS complexes. If we use our box method, where we know that each box here is 0.2 seconds, and we want our QRS complex to be less than 0.12 seconds, we have this QRS complex alone that's going to be about 0.28 seconds, which is more than double what we should be looking for. We can see here, a good way to think of this is this almost looks like a tombstone where we can write the words RIP within it and it would fit. Here's another image I found online where we can see V-tach originating from the right ventricle and V-tach originating from the left ventricle, which I just thought was really cool. I'm not too sure about the specificity on that, but if that is really a thing, then that's good to know. But again, we can see the wide QRS complexes here, and you can see they extend well over 0.12 seconds, which would be 3 little boxes. For the treatment, it's the same thing as VFib, as long as they don't have a pulse. It would be CPR with the BVM, defibrillation. It is also a shockable rhythm. Epinephrine 1 to 10,000 every 3 to 5 minutes. An antiarrhythmic drug such as amiodarone or lidocaine. And again, we're not going to go over full codes on this. For asystole, what we're looking for is basically a flat line. It's almost going to look like this, but horizontally. And we want to check for a pulse at all times. Why does it occur? It's a prolonged cardiac arrest usually, a massive myocardial infarction. It can be caused by severe hypoxia, metabolic acidosis, and end-stage heart disease, although there are other reasons why this occurs. This is just one of the reasons. Here's an image of asystole, and you can see it's just kind of like a flat line. There's really nothing to read here. We can sometimes almost get confused with fine VFib. If we take a look back here, where it almost looks like a fine line, but you can see this pulsating going on. But for asystole, it's just basically a straight line. Usually you're not even going to see this small curvature. Here's another image of asystole. Same thing, where it's pretty much just a straight flat line. This is not a shockable rhythm, so when we look at treatments, it's going to be CPR with a BVM. No defibrillation, it's not a shockable rhythm. It's going to be epinephrine 1 to 10,000 every 3 to 5 minutes. You're not going to use an antiarrhythmic drug such as amiodarone or lidocaine. And again, we're not going to go over a full code algorithm, but these are just things to note. It's not a shockable rhythm. We're really just going to go for quality compressions, BVMing our patient, and administering epinephrine. For PEA, or Pulseless Electrical Activity, we're looking for basically a regular sinus rhythm, but it can also be a tachycardic rhythm, other arrhythmias, but they don't have a palpable pulse. So if we do a pulse check, we say, oh yes, our patient converted from VFib to sinus rhythm at heart rate at 40 beats per minute, so it's sinus bradycardia. But we palpate a pulse. If we can't feel a pulse, then we have to say, okay, this is actually PEA. We need to continue with compressions. Why does it occur? Usually it's from hypovolemia, not enough blood, tension pneumothorax, a possible collapsed lung, or a compression of the heart, cardiac tamponade, which is fluid around the heart that's restricting its pumping capabilities, or a pulmonary embolism, which is blocking blood flow to the lungs. There's other reasons why this can occur. This is only some of the few reasons why this can happen. So here's an image of pulseless electrical activity, and if we look at our rules, well, I see a P wave. The PR interval is pretty good. I would say that it is less than 0.2 seconds. The QRS complex is less than 0.12 seconds. The P waves match with the P waves. The QRSs match with the QRSs. So you would think, oh, great, this is a good rhythm, right? Well, if we palpate a pulse and we can't feel anything, then while we could argue that this is potentially like a sinus rhythm, the electrical conductivity, for whatever reason, it is not causing contraction to the heart. Even though this is a good electrical rhythm, it doesn't matter if it's not causing any contractions. That's why we don't feel the mechanical pulse. Here's the second image of PEA. And again, we have our P wave here, right? It's less than 0.12 seconds. We have our QRS complex. It's less than 0.12 seconds. The P waves match with the P waves. They match with the QRSs, and the QRSs match with the QRSs. Our PR interval looks good. There's only one P wave for every beat. However, if we don't feel a pulse, it doesn't matter. This would still be considered PEA depending on our patient's presentation. So some treatment, you want to do CPR with a BVM. It's no defibrillation because it's also not a shockable rhythm. You can treat this with an epinephrine 1 to 10,000 every 3 to 5 minutes. You cannot administer an antiarrhythmic drug such as amiodarone or lidocaine. We're not going to go over a full code here. But besides that, guys, thank you so much for watching. Understanding cardiac arrest rhythms is crucial in EMS and ALS. Each type has unique EKG features and treatments that are necessary. Be sure to review the playlist for more on EKG interpretations. I will see you on the next one. Thank you, guys.